Gonna go straight to the point with endocarditis, right? What's endocarditis? It's basically an infection of the endocardium, which, as we all know, is the inner lining of your heart chambers, right, and the heart valves. Okay, now endocarditis can actually be bacterial or fungal infection. Okay, and usually it can be fatal if left untreated, but with proper treatment, most of our clients will recover. Okay, the problem with I'm sorry, guys. The problem with endocarditis is that it can infective endocarditis can cause severe valvular damage, which can eventually lead to insufficiency and heart failure, which is really bad. So we don't want that. Okay. Now, what are the possible causes? Now, the main possible causes are staphylococci, which is Staphylococcus aureus, and also streptococci, which is Streptococcus viridian. Okay. Now, looking at the assessment, how do we assess our patients? Aside from the usual fever, chills, and fatigue, the patient can also have uncommon um, symptoms, right? Uncommon in other diseases such as rot spots, right? And rot spots is basically when you see white centers on the retina of our patient, and those white centers are actually hemorrhagic areas. Okay. Another one is osternodes, which is basically just tender raised lesions that can be found on the finger or in the toes. Okay. And lastly is valvular insufficiency with our patient's heart valves. Okay. Now, diagnostics. How do we evaluate the diagnosis for the patient? Usually, echocardiography can reveal a valvular damage, and usually the EKG can also show some arrhythmias, right? But the main diagnostic would be blood cultures. Now, there's actually three blood cultures taken at 1 hour intervals that is done in order to enable us to identify the actual causative organism that is causing the patient's endocarditis. Okay. Now, in regards to treatment, bed rest is important. Also, sufficient fluid intake, and also in severe cases of valvular damage, we do need surgery in order to replace the defective valve. Okay. Now, with drug therapy, we can give our patient antibiotics, which obviously would depend on the infective organism, right? We can also give antipyretic, such as aspirin, and anticoagulant. And usually, with a patient with endocarditis, the main anticoagulant that is used is heparin. Okay. Now, what I want you guys to really take note is that you need to watch for signs and symptoms of embolization. Now, embolization, as we all know, is just formation of embolus that might lodge into the bloodstream of the patient, right? So we need to watch signs and symptoms of embolization, such as hematuria, pleuritic chest pain, left and upper quadrant pain, right? Because embolization can actually be a common occurrence during the first 3 months of the treatment, okay? And these signs and symptoms can indicate an impending peripheral vascular occlusion or a pulmonary infarction, which can be bad for a patient. Okay. Now we can talk about tracheostomy. Now, tracheostomy, on the other hand, is the stoma or the opening that results from the tracheotomy. And what this does is it allows the insertion and the maintenance of the cannula, right? Now, usually a double lumen tracheostomy tube has three parts, okay? The three major parts. It's the outer cannula, the inner cannula, and the obturator. Now, the outer cannula is just the one that fits into the stoma and keeps the airway open. Okay, so that's really all it is. And the inner cannula basically helps locks the outer cannula into place. Okay, and the obturator basically helps and allows the outer cannula insertion. Now, the main thing that you have to know with the obturator is that with the obturator, it is removed immediately after the outer cannula insertion, and it's always kept with the client at the bedside, okay, in case of what we call an accidental decannulation, or if the cannula falls off, okay? So this has to be in the patient's bedside. Now, our patient is at risk for aspiration, okay? Now, swallowing is actually possible with tracheostomy, with a tracheostomy tube in place. However, there's what we call a laryngeal elevation, right? And it's affected, and therefore we do need to assess the patient's risk, right? The patient is going to be risk for aspiration. Therefore, prior to any intake, whether it's medication or food, we do have to assess the client for aspiration. Okay. Lastly, inability to produce sound. Okay, so what's going on is that the airflow in and out of tracheostomy usually would bypass the vocal cords, right? And obviously that would result in the inability to produce sound or speech. So that's basically it. The airflow in the tracheotomy bypasses the vocal cords. Okay. Now, again, guys, I just want to keep this short and straight to the point so you really know the most important major points, such as the obturator, right? That is very important to have it at the client's bedside. Thoracentesis, okay? Now, what is thoracentesis? Thoracentesis is basically a surgical perforation of the chest wall and the pleural space, okay? Now, what that basically means is just a surgical insertion, right, of a large bore needle into the chest wall of our patient, okay? Now, this is usually done to either to obtain specimen for usually diagnostic evaluation. This can be used for medication, such as instilling medication into the pleural space, okay? And it can also be done to removal of effusion or air from the pleural space. Now, when I say effusion, that basically means fluid, okay? So it's basically the removal of fluid or air from the pleural space for usually therapeutic relief or pleural pressure, okay? Now, usually our patient is given a local anesthetic, okay? And usually the patient, the procedure can be done at the client's bedside, or usually at a procedure room by the physician, okay? And now, in regards with locating the effusion site or the insertion site, what we do is in order to locate the needle site, we're gonna percuss the patient, we're gonna auscultate. We could also do radiography and sonography, okay, to locate the effusion. Now, how do we assess our patients? Usually, there would be obviously a decrease in breath sounds, okay? There would be a decrease in chest and wall expansion, and there would be a lot of pain, and the pain is usually due to the inflammatory process, okay? Now, in regards, this thing is very important that we need to know about is fluid removal, okay? You need to know that the amount of fluid removed is limited to 1 liter at a time, and this is to prevent cardiovascular collapse to our patient, okay? That's thyroid storm, or what we call thyrotoxic crisis. And basically, we all know it's a complication of hyperthyroidism. But what it is it's a severe complication, right? Because what occurs is that there's a surge of large amounts of thyroid hormones going straight into the bloodstream, causing a severe increase in the metabolism in the body. And this is actually considered a medical emergency because this has a very high mortality rate, okay? Now, another thing that you want to take note is in regards with thyroidectomy, which is basically a surgery, and this can also be a complication after a subtotal thyroidectomy, because what occurs is there's a lot of manipulation of the gland during the surgery, and this can in turn cause a thyrotoxic crisis, okay? Now, in regards to signs and symptoms, we do need to take note that a patient could have hypothermia, could be hypertensive, and there would be a lot of abdominal pain, okay? Now, interventions as a nurse, we do need to maintain a patent airway, and we do need to continuously monitor the patient for dysrhythmias, okay? Now, we can also give the patient acetaminophen, but aspirin is actually contraindicated for this patient because with aspirin, what it does is it can release what they call thyroxine within the protein binding sites, and this in turn can be bad for the patient, okay? Now, lastly, we do need to give IV fluids as prescribed by the doctor in order to hydrate the patient and also to help prevent vascular collapse, okay?